The last title is Thinking Differently About Differentiated Thyroid Cancer in the Genomic Paradigm. Well, we still have an equipoise when it comes to the initial surgical treatment of and initial radioactive iodine treatment of thyroid cancer and the subsequent treatments as well. Equipoise is what I prefer instead of saying controversy. Equipoise is a situation that there is not a single better choice of intervention present in a given clinical predicament. Essentially, everybody with different opinions have good reasons to believe what they believe is right. And there is really not a good single right answer. In a state of equipoise, as I just said, both sides have reasonable basis for their choices and can present plentiful data to support their positions. Again, the state of the affair regarding the extent of initial surgical treatment and appropriate use of radioactive iodine stand at an equipoise. Equipoise means, or it's a sign of a knowledge gap. I'm going to start with tackling the term papillary cancer. And I think this term is one of the many reasons of this equipoise. In the lower left side, you see the embryogenesis of thyroid gland. Precolloid phase is marked by sheets or groups of clusters of cells with no organization, no structural organization. And it is up to the 10th week of the embryonic phase. Then comes the colloid phase, where you start seeing some colloid accumulation in the picture, but there is still no organized follicle formation. It's only after the 14th week you see some follicular structures. In the blue background, you see the adult mature thyroid gland, and the far right, you see a papillary thyroid cancer. Papillary structure, papillary morphology is not in the natural differentiation phases of thyroid gland, neither in the embryonic phase nor in the adult phase. Tomorrow, I'm going to tell you the history about naming papillary cancer as differentiated thyroid cancer, not looking like any of the fetal phases or adult phases of thyroid gland. Morphologically, papillary thyroid cancer is not a differentiated cancer or well-differentiated cancer. Perhaps at best, you can say it's a misdifferentiated thyroid cancer. It is differentiated, obviously. It's differentiated to a papillary morphology, but functionally, how much of the original function did it preserve? Again, most papillary cancers may not qualify as well-differentiated thyroid cancers. Philosophical problems are created by misguided attempts to consider the meaning of words independently of their context. So everything should be considered in its own context. It's, I think, a little more than semantics, and I'm going to open this to discussion and debate at the end of my presentation. How do we disrupt the equipoise? Again, well-differentiated thyroid cancer is a misleading term. We all think when we hear well-differentiated, we believe that that thyroid cancer has an excellent means of picking up radioactive iodine. Therapeutic significance of total thyroidectomy, and I think this is a very important point, is coupled onto the radioactive iodine therapy, as first demonstrated by Dr. Rawson and first elegantly stated by Dr. Beer-Walters. The reason, original goal, original intent of total thyroidectomy was to facilitate radioactive iodine therapy. Therapeutic power of radioactive iodine in a misdifferentiated thyroid cancer is gauged due to the tumor indifference to radioactive iodine. And molecular theranostics has the potential to revert this dialectical error. What's the definition of molecular theranostics? Is an emerging new technology potentially to change the landscape of thyroid cancer management. The theranostic power of radioactive iodine can be gauged from molecular theranostics. Molecular theranostics include identification of the molecular or mutational profile, all the molecular markers in the form of genomics or transcriptomics to be disclosed. And last but not the least, the thyroid differentiation score can be not as yet could be included in this molecular profiling. Another important piece is that the role of radioactive iodine theranostics and therapeutics, if you could identify the role of radioactive iodine, you could define the role of surgery. Therefore, obtaining this information preoperatively is more important than obtaining it post facto after total thyroidectomy is done. So this is the upcoming new paradigm. We all shoot for 2023. Thyroid nodules are initially approached by fine needle aspiration biopsy and cytology, Bethesda classification, and the majority of the world and majority of the institutions in US, it unfortunately stops here. Surgery versus no surgery, total thyroidectomy versus lobectomy, lymph node dissection versus no lymph node dissection have to be made based on the Bethesda classification and ultrasound findings. And these are all nicely, very elegantly detailed in the ATA guidelines. Then we perform our surgery. The molecular profiling is again not a routine piece of postoperative assessment. We define risk factors based on standard surgical pathology, looking at the basic morphology, capsular invasion, vascular invasion, lymphatic invasion, the size of the tumor, resection, whether it's R0 resection, R1 resection. These are all the standard classic forms of identifying risk factors and deciding on what to treat with, how to treat with. And as I mentioned in my previous talk, tumors with high risk features may have substantially more depressed thyroid differentiation score and may not be responsive to treatment as we expect as we approach today. So this is what is open to discussion and debate, and I will ask all our participants, including the audience, to ask questions and comment. Now, few words on radioactive iodine refractory disease. There are three concepts under this heading: indifferent, inadequate, and resistant. Basically, essentially, you have four reasons. One, tumor is indifferent. Two, you're not Dr. Van Nostrand. He is absolutely right. Not all the scans are created equal. Not all the treatments are given efficiently, effectively. This is the single most important piece in terms of technical aspect of radioactive iodine theranostics. Three, you may not give enough dose, absorb dose, not adequate radiation absorbed dose. And four, your tumor may be radioresistant, which is a different concept. I'll give two examples. This one patient is a young woman who had Costman syndrome and had a locally advanced papillary cancer with multiple lymph node metastases. She had NTRK3 translocation, which falls in their intermediate category between BRAF and RAS-like tumors, with expected thyroid differentiation score somewhere in between. In her case, it was 1.7. She received 150 millicuries of radioactive iodine treatment. And the Kostman syndrome you have, and she had prior history of leukemia treated with bone marrow transplant. She received 150 millicuries with an excellent response. This obviously is a radioactive iodine avid and responsive thyroid cancer. The second patient who presented with left shoulder metastases proved to have multiple metastases. This is pretty much the highest number of mutations one could see in a typical thyroid cancer. She had NRAS mutation, TERT mutation, TP53 mutation, and IFAX mutation. She initially received, first of all, she had a total thyroidectomy performed, and then following total thyroidectomy, received 350 millicuries maximum tolerated activity radioactive iodine. And then over the course of 2 years, she received a total of 725 millicuries of radioactive iodine. At the end, as of last month, she still has significant disease, as if she did not receive any treatment, except for the skull lesion that disappeared. And all lesions are also FDG positive with a reasonable TDS score. So this is a heavily treated patient, radioactive iodine avid, but refractory. The question is this an intrinsic resistance issue in terms of radiobiology? These are the things I'd like to open for discussion. I would be happy to receive feedback from Dr. Van Nostrand and Dr. Lusser, and then Dr. Greenspan. I think I'm going to end here to leave more time and platform for discussion. Thank you very much.